Hello team, my name's John Wells. I'm a charge nurse at intensive care at Barts. We're going to talk about pumps. What you do need to know is that we have two types of pumps. We have the syringe drivers at the bottom, which you will mostly be familiar with, and then we have what we call peristaltic pumps. Peristaltic pumps because they work by squeezing the line. The beauty of these pumps is they have a drug library, and at the top of the pump it tells you what drug you're running through the pump, and even better, when you're running the pump it tells you the dose in the appropriate format. So this pump is noradrenaline running 0.01 mics per kilo per minute. Now, why do we use a peristaltic pump instead of a syringe driver? It's all about ease of use and half-life. So we can't afford to interrupt the noradrenaline, because the noradrenaline, if we stop it, their blood pressure will drop almost immediately. So rather than switching syringes, we have them on a peristaltic pump. To change your fluid on a peristaltic pump, all you have to do is get the new one ready, hook it, pierce it, put it up, and change your volumes. No interruption to flow, which is very useful. The reason we use it for propofol is because propofol comes in bottles, and if you imagine that my nurses and I had to draw up 50ml syringes of propofol running at 30 mils an hour, we would spend a great deal of time drawing up syringes of propofol. It saves a huge amount of time. Now, that's a useful hint with pumps, is if we can't afford to stop it, it will be in a peristaltic pump. If we can, if it doesn't particularly matter if it's interrupted briefly, it will be in a syringe driver. So down here we have Vasopressin. Its half-life is such that you can stop the pump, change the syringe, and it doesn't really make any difference. Hence, the data sheet says you can draw it up in a syringe. Fentanyl, similarly, an analgesic, an opiate analgesic, it doesn't matter if you interrupt it briefly. Hence, you can put it in a syringe driver. Now, you will hear them alarm, and one's doing it now. That's a typical alarm. That's because I haven't pressed go. That's another alarm. That's because it's open. If you hear the alarms, don't ignore them, but what you must never do, never turn off the pump, because I lose all the data and then I've got to reprogram it, and that takes a lot of time. It will pause itself. And so flag up the fact that there's an alarm or a problem with the pumps and leave us to deal with that. Remember, very usefully, I'll say this again, here we go, another alarm, you'll hear a lot of those. It tells you the drug, it tells you the dose in the appropriate format. So if you're not sure what the patient is on, you can come up to your run of drugs and go, so I'm on NORAD, propofol, fentanyl and vasopressin. Now, for those of you that aren't familiar with vasopressin, for the purposes of this discussion, vasopressin is just a different flavour of noradrenaline. Essentially, they both squeeze you when you are dilated. People get very worried about vasopressin and think it's a lot. It isn't. The maximum dose of vasopressin that we run is 0.04 mils an hour. It is not weight mediated. So, if you're on 0.04 of vasopressin, what I want you to do is think of that as very roughly the equivalent of 0.1 of noradrenaline. So, if you're on 0.1 of noradrenaline, 0.04 of vasopressin, you're on roughly the equivalent, if you were using a single agent, of 0.2 of noradrenaline, in a nutshell.